I want to start with giving the floor to Clarissa Giebel. She is from United Kingdom, and she has done already a lot on COVID-19 and social support. And she is going to talk about service closure and mental well-being in older adults. The floor is yours, Clarissa.
Thank you very much, Myrra, for inviting me. Pleasure. As Myrra was saying, today I'm going to give a very brief overview of what turned out to be a far larger study than we anticipated at the beginning. I'm going to talk to you a bit about our UK longitudinal survey, which was a mixed methods approach. So we also conducted some qualitative research as part of this, really to try and understand very early on in the time period of the pandemic, how the pandemic and how these public health measures have impacted on older adults, including those living with dementia, and on unpaid carers. So first of all, initially we started out exploring specifically people living with dementia and older adults living in the community. And subsequently, we also conducted a care home study, which was complementary. But for this particular talk, I'm only going to talk about the community-based research that we've conducted. So when it first starts, so in the UK, we had the official national lockdown for all 4 nations. So that's England, Wales, Northern Ireland, and Scotland, on the 23rd of March, 2020. And we were really lucky at that time. Well, lucky, I might say. A few days later, we received some research funding enabling us with a large group of public advisors, so carers, a person living with dementia, as well as third sector organizations and healthcare professionals, trying to understand, okay, face-to-face care is so crucial for people living with dementia, but also support for unpaid carers. How are these public health measures going to impact on those services and on the well-being of people? So when we talk about social care and social support services, what we referred to mostly was, for example, daycare centers, paid home care, befrienders coming into your home, as well as respite care and support groups and social activities in the community. So really things a person living with dementia or an unpaid carer should receive once they have received their diagnosis. That's not always the case, but in an ideal case scenario. So just a little bit of background information before I go into more detail about the survey, because as I mentioned before, it was a mixed methods approach, and really the qualitative element really complemented what we found in the survey. So in this qualitative remote study, in April, we conducted 50 interviews with unpaid carers and people living with dementia. And 3 months later, we followed up 20 of those carers and people with dementia, trying to understand what might have changed, how their life has changed. And really early on, so already in April, we found that quite a few unpaid carers noticed that their relatives with dementia were apparently deteriorating faster cognitively and physically because of that, well, lack of social stimulation, lack of going to those support groups or other support services, and just being confined to the home environment. And we also noticed one type of social support which will feature specifically in the survey as well was paid home care. It kind of stuck out both in the interviews and in the survey findings, in that there were really difficult decisions that unpaid carers were making and facing about whether someone should continue to receive paid home care or not. So again, that was in the first few months of the pandemic, but still these issues are still apparent, especially now in the emerging new waves and strands of the pandemic, of the virus. But what we found was that so many carers were so worried about having effectively a stranger coming into the home environment, potentially spreading the virus. And also we found that there were lots of different variations of how much or how little PPE a paid home carer was wearing. So some unpaid family carers decided, no, I don't want to have that risk. I don't want someone strange to come into the home environment. So they cancelled care. Effectively, that led to higher levels of carer burden, though, which we found out a few months later, because they took on those additional caring duties. But some family carers or friend carers were saying, we can't cope without having a paid home carer coming in. We just need to take that risk. And they continued with paid home care. And this will be reflected in the survey findings a couple of slides in. But it's just really interesting to have that more in-depth and nuanced background as to why paid home care featured specifically in those different types of support services. So we found loads more in the qualitative interviews, but I wanted to give more of a focus here on our survey. So in the interviews, we only focused on people living with dementia and unpaid carers. But for this UK-wide survey, we also included older adults because we thought, okay, they will likely suffer from social isolation in particular, which is already high before the pandemic. And we also wanted to ensure that as many people as possible could participate in the survey. So we not only did it online, but we also actively, via third sector organizations, such as the Lewy Body Society, or the Brain Charity, they helped us with this. They contacted people to complete the survey over the phone. And what we've done in this survey, we co-produced the survey together, as I mentioned before, with carers, a person with dementia, as well as third sector organizations. And we asked people specifically what type of social support services they have received prior to the pandemic, so pre-time point 1, and then at 3 subsequent time points. And you can see here the periods of data collection from T1 to T3. In addition to that, we also asked people about their socioeconomic backgrounds because we wanted to understand, are there any inequalities in them accessing this? But also we asked people established questionnaires about their mental health and well-being, including the GAT-7 for anxiety, the PHQ-9 for depression, and the short WEMWEBs for quality of life and well-being, amongst others. And you can see here, obviously, as to be expected, we had a larger number of participants at baseline. But overall, we still had around 400 people completing all 3 time points of the survey. And I'm just going to give a brief snapshot now. Move this. So at the baseline survey, we had to exclude a few cases because of missing data, etc. So overall, at the baseline survey, we had 569 participants. And I just wanted to highlight here, because we looked at what type of services were used pre-pandemic and then at time point 1. So apologies about T1 and T2, but it's actually pre-pandemic and time point 1. And then for current carers as well. And you can see here that I think what's quite interesting here is to see the bar of none, who received no support at all. And this is really high for people living with dementia. So before the pandemic, maybe 35% approximately of people with dementia were not accessing any type of support. And after that, social activities were the most prominent ones. But then during the pandemic, in the first few weeks, first couple of months, half of all participants interviewed that were living with dementia accessed no support at all. And this is really important, especially in the long-term implications for this. And equally for carers, as you can see as well, around half of current carers did not access any support. And now here, let's have a look at the longitudinal data. So service usage by time and time point. So we highlighted here specifically a selection of different types of social support services. Now, these are all, the participants are all grouped together. So what you can see here is older adults, current and former carers, as well as people living with dementia. That this is our population. We're looking jointly at them. And then we're looking at those 4 time points, pre-pandemic until time point 3. And as I was saying before in relation to our qualitative findings, paid carers, whilst you can see across all of these services, there was a dip from time point 1 in particular. Paid carers seem to be bouncing back quite a bit, so, because it was supported by our qualitative findings with carers saying they couldn't cope without it, and paid carers still were coming into the home. So this seemed to be the least affected type of support. But as you can see with the other activities, throughout the time period of data collection, they have not bounced back. Support groups were the only ones bouncing back a tiny little bit. That's because early on, support groups started to become remotely provided. But daycares, befrienders, social activities, that's difficult. And also, as I mentioned before, we did look at depression, anxiety, levels of depression, levels of anxiety, and quality of life. And we did find that reduced access and use of those support services at the baseline survey was linked to increased levels of anxiety in people with dementia and older adults. So really a link to mental health and mental well-being. And reduced access and use of services was also linked to poorer mental well-being in unpaid carers and older adults. So that was measured via the short WEMWebs. So again, now we think that was in the first 3 months of the pandemic. Now we're almost coming to 2 years of a pandemic and different levels of restrictions, growing waves and infection rates again. What are the long-term implications of this on the mental health of people affected by dementia? So some of the learnings from the pandemic so far and from this research was that we found that remote support is not the same. It's a lifeline, an important lifeline, but it just does not provide the same support. We found also exacerbated inequalities in accessing care, especially when we think about digital and remote access to support groups, for example. And we thought that services should try and provide safe face-to-face support where possible, obviously, just because only remote support doesn't really provide the same benefit. And as I just mentioned as well, there's a need for mental health support. And we have summarized these findings in a policy briefing as well. And just a couple more pointers now to something ongoing that we're doing. So based on this survey and based on the qualitative interviews, we were approached by 4 countries. So we have since, or the collaborators really have collected an awful lot of data, and there'll be much more about this tomorrow in a session. But we have joined up with a team in Poland, a team in Italy, in India and Australia. And yes, so it's really interesting to see how the pandemic has affected dementia care on a global scale. So that will be really interesting to look at. And also, lastly, really following on from this, we are now currently conducting a systematic review into the effects of the pandemic on people with dementia and unpaid carers, which originated from this first study. And together with collaborators in Germany and Australia, we're looking at specifically the impact on health and mental health and cognition, social care access and use, and also financial implications of the pandemic. And that's me, and just a slide to say thank you to everyone that's been involved.
Thank you so much, Clarissa. And it's great that you embarked so early on in COVID-19 research. It's very good to have data. There's a lot of talking, but when we have data, it might make it makes a difference. I do have one question. I do have more, but did you see that after the lockdown, so in the periods that there was no lockdown, that things tended to be more like normal in service use?
We, a little bit in the survey, because the quality, so we had a lockdown from 23rd of March until around July time, and then it was a little bit eased, but the qualitative data were only collected before lockdown eased. So in the survey, which was conducted lastly in August, we did notice that there was a little bit of a bounce back of services, but only very little. And when we spoke to providers who are part of our research team, they also said, well, we've very slowly started opening up our support group face to face, but obviously that all went closed again with the third lockdown in November. So.
Okay, thank you so much.
Thank you.
And then we move on to the second presentation. It's kind of co-presentation of Heinrick Wiegelman and Marta Lenart. And they are both members of the shared project, and they are working really very hard on several reviews, and they are going to present the review on measures in the context of social health. And Heinrick is from Bremen and in Germany, and Marta is from Wrocław in Poland. I don't know who is going to start. The floor is yours.
So the current aim of our team is to focus on the review of the measurement of social health. So that's why I will try to introduce you a bit to this particular work and to the preliminary results that we are able to present, and to say that this is a very first draft of the result. So in general, and as Myrra introduced the social health concept before, we are trying to adapt this concept to the practice, checking how is it compatible to the research that is already in the literature, plus to apply this concept to the current analysis that we conduct in our project among many cohorts, international cohorts. So in general, we know that this concept refers to the role of social abilities of an individual and the social network. And there are many concepts and terminology around that concept that we can hear in the literature about social participation, but also the social abilities, social roles. And there are so many words and so many terminology that sometimes we get lost. So our aim of our quite a big team was to decide how can we actually measure that concept? Can we say that this is only in theory, or actually can it be in practice as well? Can we somehow make it unite and also make it comprehensive, but at the same time very empirical in its borders? So we noticed the gap in the literature that the authors use social factors in the context of dementia, but we lacked the one tool, or at least several tools, that can actually take the two perspectives, the individual perspective and the perspective of the network. And here you can see the concept that covers 6 domains on 2 levels. The first level refers to the individual perspective with the capacity to fulfill potential, with the autonomy and ability to participate. And on the second level, that refers to the social network that surrounds the individual. We can characterize 3 different domains that refer to the structure of the network, the functions that the people of the network serve, plus the appraisal, so how the individual actually assess the quality of the relationships that the person is having. Below, in the on the green color, you can see the examples of the markers. We identified those markers in the process, and I could say, and maybe Heinrick will agree as well as Myrra, that it is an ongoing process, that those markers are based on the literature review, on the group model building, on many discussion panels, plus the current and the previous analysis of the cohorts that are included in the shared consortium, some from international databases. So we know that it is still continuing, and that we can still put more markers in the domains. So I will now show you what is the aim. So what do we want to actually to do, and what we are doing is that the aim of the study is to find out and to identify and to categorize the instruments, but only the validated instruments that have been and are still used in the literature, in the research, that are measuring social health or social factors in general, but we want to categorize that in social health concept. And we somehow limited our research only to the articles that refer to cognitive functioning in general. So either cognitively healthy individuals with cognitive decline and in dementia, of course. In addition, we want to identify the research gaps. So which domains of social health concept are actually lacking the instruments, which domains needs to be further I would say developed or maybe research, that we want to highlight and pinpoint the instruments that need to be developed or maybe validated. So to introduce you to the methods, we checked 4 databases, and we limited our research only to the articles in English and to the 20 years. So from the 2000 to 2020. Also, we checked the reference lists that were quite rich in the new articles. And we use this block building approach to combine those 3 elements. So those 3 blocks that refer to the cognitive functioning, that refer to the social health domains. So we used all of the words, the terminology that were somehow connected to the domains, plus the measuring instruments, of course, to limit the search. And that bring us to 5,500 articles for the title and abstract stream. We are after that, but Heinrick will show you more details. Our eligibility criteria, we split them for 2 steps, as we can say. There were 2 processes. So first the title and abstract, then the full text, because during the full text screening, we actually had to narrow the criteria to be more specific, because as you could see, we had very many articles that were not in the scope of the topic of our review. So we decided only to focus based on the discussions with our members and our members from Interdem and social health stream, to narrow the instruments only to the validated instruments, in order to get rid of all the single ones or single item instruments, or all the instruments that were used only once by the authors that developed the instruments for the purpose of their study. So here are the eligibility criteria, and then we also decided to extract much data that are now being analyzed. So we grouped the data that we extracted into 4 groups. Or actually, I could say 5, because the data was the categorization of the particular instrument, so the particular marker that has been measured in the instrument, to the social health concept in the 6 domains of social health concept. So as you can see, we have the basic information, we have some information about the design of the instrument, then we have more about the psychometrics of this instrument, and the 4th line, which is all the application. So what were the study settings and information about the participants. So as you can see, we made a very comprehensive table in order to also to identify the gaps and the missing data, and to pinpoint where the authors do not provide enough information. And I can handle the microphone to Heinrick now.
Yes, thanks, Marta. So I take over now to present you some preliminary results. I'm going to start with classical first result, the flow chart and the results of our screening process. Marta already talked about that. Maybe the most striking point is really the huge number of studies we have included, starting with 10,000. Then we had 5,000 after duplicate check, and we ended in the end after screening titles, abstracts, and full text with with 270 articles for the data synthesis. which is still a very high number of studies, I guess, for a systematic review, which is maybe due to the social health concept Marta introduced to you, which is a quite inclusive and a broad meta concept, and which features or which brings together a number of concepts that are already quite broad in their own terms. So this is maybe one reason why we have such a high number of articles in our final sample. Yeah, we reviewed the literature of the last 2 decades. So it's obvious that that the illustration on the left side is only showing these years. In summary, we could say that the number of articles is quite stable at the beginning. Then we have a kind of dynamic process until 2010, a small dip in 2017, and a peak again in 2019. Of course, this kind of table is always a bit, has some limitations due to the delayed inclusion of articles in databases, or as well of the date of the search itself. But this illustration shows that we finally included 270 articles in the final sample. On the right side of the slide, you see the articles by the top 5 countries of origin. So it's quite common distribution, with the USA on the first place, UK, and so on. But I don't want to spend so much time on this, so we can maybe go to the next slide. He identified a total of 366 social health relevant instruments that were used in all the articles. So thus, in a number of studies, more than only one interesting article or instrument is used. So we have more applied instruments than unique instruments, of course. What you see here are the most frequently used instruments in our final sample. So by far the most commonly used is the Lawton and Brody IADL, for example, which is a scale that measures the ability to manage life with some degree of independence. Other similar instruments in these top 10 are, for example, the Bartle Index or the CUTS ADL scale, or the Functional Independence Measure. We have also some, on the other hand, some instruments that measure social relationships or social support, like the Lubin Social Network Scale, or some feelings of loneliness, like the UCLA loneliness scales. So it's a quite broad range of different instruments measuring different domains of social health in this table. As you can see, these are only the 10 most frequently applied instruments, but there are several more in our final sample. Yeah, for today's presentation, we have made an early preliminary classification step of the instruments into the 6 social health domains that were presented by Marta. The classification is, of course, very likely to change as it had not yet been consented within the teams of authors. We were able to identify a total of 144 unique instruments, and we tried to map them to the 6 social health domains. The instruments were assigned a total of 199 times. So again, there are multiple classifications. So several instruments could not be clearly assigned to one of the domains, which is often due to their multidimensional nature. For each of the domains, we were able to identify instruments, most in the second domain, the ability to manage life with some degree of independence, which is probably due to the widespread of the measures that, of the tools that measure independent living skills, for example, the ADL or IADL tools. If we take a look to the other domains, these are really kind of on a fairly similar level. Some reflections and an outlook. Some challenges we faced during our study so far is that we saw a quite widespread use of non-validated instruments, for example, like single item instruments or kind of arbitrary collected items used to measure social health relevant aspects. We faced a kind of a messy reporting about the instruments used, and no consistent naming, missing psychometrics, or imprecise referencing. We saw instruments that were developed for more general population, but applied in dementia context. And we face some difficulties with the categorization of instruments to the 6 social health domains, since they are often multidimensional and fit to several domains, of course. For us, the next interesting steps are, of course, again, a discussion of the social health concept and a consented classification of instruments in a discursive process with the other authors, and so that we find a common sense of how we could classify those instruments to social health domains. Yes, I guess that's it. Thank you very much for your attention.
Thank you very much, Heinrick and Marta. I was looking forward to see the first results of your immense work, and there are still a lot of challenges ahead, but you made this very important step. About the challenge of having many instruments who are multi-dimensional, how would you like to solve that?
I think this is a question we haven't solved so far. So we were discussing that. So we were also discussing if it must be that every instrument has to be in the single domain, or if even an instrument, if it has several well-validated subscales, can be also in 2 domains of social health. So, but I think that this is kind of a general question we have to solve within the team of authors, that we make a decision how to classify those instruments which are clearly at the border or lapping, or have a kind of overlapping between several domains. So yeah, I think this is an ongoing process.
And what are your thoughts?
Well,
what
if I can,
would you like to do?
So I believe that the problem is not with the multidimensional of the instruments, because we know that there can be multidimensional, as one instrument can measure the social participation, but at the same time can have items about loneliness, and that's fine. But at the same time, we need to get rid of the markers that can be classified to more than one domain. So for now, we are facing more the clearness with the markers, that we agree, and that we have a joint agreement between the authors of that review and all those that are interested, that the marker can be identified only in one domain. And then the categorization of the instruments, that we know that, for example, one instrument can measure 2 different markers, it's fine. And maybe I hope maybe that is the idea, that the further step after this review would be a proposition of an instrument that actually cover the whole social health concept. So it will be multidimensional, because social health concept has 2 levels. So this instrument proposed by the group of authors based on this review can bring the instrument providing the measurement on 2 levels, both the individual and social network.
Yeah, okay, that makes sense in my mind, at least. I'm Myrra Vernooij. I'm a medical sociologist by training. I am the former chair of Interdem, and I'm a member of the shared team. And my talk will be on social health and prevention. And being part of the Interdem group, I show the picture that Interdem members have seen this morning already. This is 2 years ago. That was our last face-to-face meeting. And we have a lot of task forces, and one of the task forces is on social health, meaning that we have a dedicated commitment to social health, regardless whether we do have a project or not. But we are lucky to have projects on social health, and I'm going to talk on this project. So first you see the Tower of Babylon, and this reflects a bit things that are going on in our shared project, because it's really interdisciplinary. We come from biological disciplines and psychosocial disciplines, and it's really about building bridges, and that has its challenges. Then I will talk more on social health and on the concept of social health and why this effort. And I will talk on cognitive reserve and on the relation between social health and cognitive reserve. And one of the problems in the project is that there is a wide variety of concepts used on social health, and meaning, and also that several concepts have the same name and are operationalized in a different way. So it's enough to cause a lot of confusion. And Marta and Heinrick already told that that's a challenge if you are looking at measures. And why do we make a case of a concept of social health? Because there are so many concepts, and you can just say, well, let's talk about social health or about social engagement. But if I compare it with apples, oranges, nuts, then you are talking about a lot of things, but it doesn't make a case. And if you want to make a case, then you talk about nutrition. Then you talk about the importance of nutrition in dementia or in preventing dementia. And this is the very reason why we want to make the case of social health. We want to have an umbrella under which all these different concepts can be shared. This is our project, and you might see Heinrick and Marta as well. I can't see your actual portrait is before the picture. And it's a GPND funded project. And our aim is to unravel the interplay between social health and biological and psychological factors. And we aim to look at the whole trajectory from normal to having dementia. Well, I want to expand more on social health. By going back, social health is in essence a relational concept. And social health is in place already since 1946. WHO has three domains of health: the physical, the mental, and the social domain of health. And social is about the consequences of human interactions and the influence on one individual on another one. So it's not on one person, it's about the relation between persons. Consequently, domains should be related to the individual and to the social environment. And I'm happy that Marta and Heinrick already showed it, because it might be easier to grasp it. So it's about the capacity to fill one's potential, the individual domains. And then you look at talents and obligations and the capacity to manage your life to some degree of independence, autonomy, and the usual thing, capacity to participate in social life. And then come the new domains, which are in fact much older, because social network research is in place for a very long time. And if you look at the social environment, what is important is the structure, meaning the family, friends, and neighborhood networks. So there are different types of network. And then there are different functions, and an important one is social support. And then there is the appraisal of the quality of a relationship. You can frame it positively or negatively. So we don't deny that relations can have a very negative, even toxic influence. So it's not having relationships. Then it's all right. It's very complicated. And we want to acknowledge this complicated thing. So here's the umbrella of social health. And underneath this umbrella can be concept like contact frequency, whether a network is built on friendship, on neighborhood, the perception of the relationship quality, competence, obligation, social engagement. So there are a lot of concepts, and they are underneath this umbrella and underneath the domains we just presented. So what our effort is, we need this concept in order to make a bridge between biomedical and psychosocial research. And I think that social health is a very good bridging concept, bridging between, and also bridging between biomedical and psychosocial, and also bridging medical things and normal life. And why do we do this? Well, it's not only, I just explained why we have this umbrella concept, but why are we looking at what we are doing now? We want to broaden the biological perspective in dementia research. It's still mainly biologically driven. And why do we want to do this? Because mechanisms are still uncured and there is no cure available at the moment. And there is great process in amyloid research, but amyloid does not tell the complete developmental story, because amyloid can be removed, but then the symptoms are still the same. And there's a discordance between neuropathology and clinical symptoms. So there must be something which we don't see at the moment, and we have to look further. And we have to look beyond only biomedical research. And also, it's not just a natural thing, dementia. It's neither a normal part of aging nor an acceleration. So we came up with a hypothesis on social health. And the hypothesis is that social health is a driver to use cognitive reserve. And we already heard it in Clarissa's presentation, the incentives that are given by interaction with other people. That is what is meant by being a driver. And it's a driver through the active facilitation and utilization of social and environmental resources. So if you take away these resources, there is less activation. And what is cognitive reserve? Well, cognitive reserve, that's our hope. We hope that if we mobilize cognitive reserve, it's good for prevention and good for dealing with dementia. And it's the ability to withstand a neuropathology by using compensatory cognitive approaches. So you can use a lot of bypasses, like here in this railroad situation. And actually, we are here at the central railroad station of the Netherlands with also a lot of bypass. I can see it from the window. Well, social health and prevention of dementia, it has not been a topic for a long time, but actually, if you look at the markers, then you can witness that there are some associations. And it has been found that social health markers, such as social network and frequency of contact frequencies and leisure activities, that they may contribute to cognitive reserve and delay of dementia symptoms. Conversely, markers of poor social health, such as poor social engagement, have been associated with incident dementia. So there are indications, there are strong indications that there are associations between social health and cognition. And this is summarized in several very important articles in The Lancet. And Jill Livingston summarized it. There are a lot of modifiable risk factors who can together prevent 40% of dementia. And one of these is a social health one, that's social isolation, so a social unhealthy one. We did a literature study on top of the many that already have been done. And we noticed that a combination of social health markers was a more significant risk factor for both the development of dementia and reduced cognitive functioning. We also found that the scores of a combination of positive social health markers showed that those who had the highest scores were 46% less likely to develop dementia compared to those who were in the lowest category. So this is very consistent evidence, and that's the important point. And then then we tried to test our hypothesis, and because these were just associations. And we are lucky that we not only have the shared project, but also a Dutch project with a large database in the Rotterdam study. And in the Rotterdam study, we studied the following hypothesis. So the hypothesis I presented is rather general, but this is more specific one that can be studied. Social health affects brain structure and consequently influences social functioning. And we used measures, social health measures, loneliness, perceived support, and marital status. And we were also able to use brain structure data. And what we found, I will come to the conclusion of this study. The conclusion is that social health was associated with brain structure, where better perceived social support at baseline was associated with better brain structure over time. All these indications have the same direction. But testing this hypothesis also comes with some shortcomings. And one of their limitations is that there is a distance between the concept of cognitive reserve and its biological substrate and measurement. So it's hard to measure. And the effect of social health and the relation between MRI assessed brain pathology and cognition, we could not examine. So we are very much aware of these limitations, but we make the first steps. So what do we learn from using this umbrella concept? What does it bring us in top of what we already know? We learned that it's about a combination of social health markers. So it's not about a single social health marker, but a combination of social health markers, which is more powerful than single markers. So this is an important point also for our discussion on measures. And what we also learn, and we know that already for a long time, that varied sources of network is beneficial for a lot of things in well-being, but it's also beneficial for cognitive health. And this means that if you only are in contact with family networks, is less beneficial than if you have a network consisting of friends and family. What we need to be done is, to build these findings to do further testing and to build this into interventions. And what kind of interventions? Well, we are thinking about, in another Interdem task force on prevention, we are thinking about how to increase public awareness of brain health, how to develop and implement strategy to stimulate brain healthy lifestyle and social health, and how to avoid social health and health inequalities. So there are a lot of more challenges, and this is really a concept in progress and a hypothesis in progress. And coming to the conclusion is that now we have a social network framework in place. It allows us to identify theory and evidence-based driven social health markers, so we can identify them. And we hope to identify mechanistic pathways and to develop social health-based interventions. And with this, we hope that we created the right conditions for social health to finally take its place in solving the dementia puzzle, and that it facilitates the development of novel social health interventions that can help to prevent dementia. And anyway, it will help to live well with dementia. And my conclusion is, on top of this, is that the value of social context should not be underestimated. Social contexts are for people like water to plants, and its value goes beyond gezelligheid, the untranslatable Dutch word for enjoying being together. It's an incentive to thinking activities required in social context. Thank you for your attention.
So there is a question in the Q&A. Interesting social health hypothesis. Will you consider the impact of different types of social contact, for example, meeting people in larger group settings and building relationships?
Well, thank you very much for this this question. It does make a difference in which context the social contexts are, but to my surprise, contexts on sich are important. There is a very interesting finding of Holt Lundstedt that people who have more chats during the day, just chats it about whatever, that they live longer. So the kind of interaction, having an interaction is very important, and it makes a difference. And also having close relationships, of confident relationship, these are important ways of having a contact. And so all contexts count, and it's very important how they are perceived. That's a kind of bottom line. And in this COVID time, I really want to stress that you should, well, keep to the safety rules, but take each opportunity to meet. Any more questions?
Yes. What do you think are the implications of social health for development of dementia-friendly communities?
Well, we are hoping, and we are getting indications that it does have an influence on prevention of dementia. And it's well, there is a rule: use it or lose it. And what we want to stimulate in whatever intervention is to use it, and how to use it. And it should be in a way that is agreeable for you. Some people prefer one-to-one, others prefer to be in a group, whatever. But this is the actual thing we are doing now. We are looking to evidence of the influence of social health on prevention in dementia. And so far, well, it's really explorative research. And I find it really exciting to find this, and even when the measures are, they are not used, not fully use the potential of measures that are, and that even with these measurements already, we have this kind of rather consistent results. So maybe it might be a good opportunity for us human beings, by being together, that we keep our mind sharp.